It's so nice to be with you this morning. And nothing like a rousing and beautiful day to get together and talk about dying, So I hope everybody is ready for the excitement of this process. So we want to talk about church teaching and the ethical principles needed to make sound medical decisions. And to do that, I want to first acknowledge the challenges that we face. And we face that dignity in our society is equated with autonomy and achievement, and dependency is viewed as a threat. Now, this was not always so. My mother, who has since gone to the Lord, used to love to go to Vietnamese restaurants. It wasn't that she liked Vietnamese food. She liked the respect for an elder woman that was given in that community. There was no dissing her because she couldn't star in the Pepsi commercials. She drank Diet Coke anyway. The anti-life mentality, artificial reproductive technology. Some of the largest reproductive technology centers in the world are located within 50 miles of here. Shady Grove and Arlington, for example. And artificial reproductive technology says that we want to control the time and the quality of new life, and physician-assisted suicide now says we want to control the time and the quality of dying too. Control, control, control. Preemptive strike against dying. Advanced directive choices need guidance. There's nothing wrong with making advanced directives. In fact, it's to be considered a good thing in many ways. But it needs guidance. So in the midst of all of this, we're facing new challenges to understand that the church is doing. Now, what do we know about dying? Well, first of all, the death rate. I've studied this very carefully. Death rates in the state of Maryland are holding steady at 100%. Okay? So this means you, and it means me. There's no deviation. So we know that but what do we know about dying? Well, 70% die in a hospital or a nursing facility of some sort, some medical facility. 70% say they would rather die at home. That doesn't happen most of the time. 80% chronic disease patients say they would want to avoid hospitalization or intensive care units when they're dying. So we have an aversion to this. 30% will see 10 doctors in their last 6 months of life. So get to know the medical profession. And 20 to 30% say that they have advanced directives. That's fairly small numbers. There's footnotes, but I'm just going to move on. What's killing us? And this is a very hard slide to see. But I think it's important to take a quick look at what's killing us. The age of death is, the bigger blocks of the age of death says 85 years and over, about 30%. Now, all of us put ourselves into that category. Okay. When are you going to die? Well, I was thinking maybe 85 would be the earliest I'd like to check out, and a little longer would be nice too. I've been to funerals of the 95-year-old died young, One of the priests up at Mount St. Mary's, when he bought his car, he was 92, he bought the extended warranty. Don't we all? Now, the cause of death, what's causing us to die? Heart disease and cancer constitute about half. They're the two things on the right you can't see. About heart disease and cancer, which means that when you see a lot of physician-assisted suicide ads about Lou Gehrig's disease, it's like as though it was happening everywhere. Now, I have known people who have Lou Gehrig's disease. I don't want to minimize the challenge of that disease. But most of us won't die of that, okay? Cancer and heart disease and Alzheimer's takes 3% as the ultimate cause of death. There are a lot of people who have Alzheimer's, but they don't necessarily die of that. They die of other complications. So if you're planning on going with one of the rarer varieties, you want to get your reservations. Who cares how we die? Who cares about us when we're dying? Well, we do. And it seems that 15 million of us in the United States, one in three of us, are involved in caring for somebody in their elder years. And this is one of the things I was able to do for my mother and father. It was a tremendous gift to be able to get to know them in that situation. And I had been a medical ethicist for years, and I thought I knew all about this. And they still had a lot to teach, and I had a lot to learn. The same thing, my sister, I have a younger sister who also passed away from ovarian cancer. So I learned about cancer dying and about her situation. She was very transparent with me in this. Now, so many of us will learn about death and dying in that way. 15 million care for dementia patients. It's hard work. Most of the care providers are women. Vast majority of them are relatives. Most midlife people who provide care are providing it to older parents. It's extra work. 1 in 6 who provide that care also have full-time jobs. 70% have suffered work-related difficulties due to being providers. They've lost wages or jobs or promotions or pensions or retirement benefits, so that it's not cheap grace. And so one of the things that we face with the decisions about end-of-life care is the reality of how it's affecting us to be the care providers, as well as how it affects those whom we love who are providing care for us. So it's not just about me and my documents. It's the broader picture, I think. And it's how do we support each other? And how do we pray for each other? And how do we provide support as a parish to be pro-life in that broader and more significant supportive sense, to counteract the cultural challenges I mentioned earlier. And we're getting older. I am, personally. It's good news, actually. And by 2030, 71 million Americans will be over the age of 65. Youthening is not one of the options. And so, but we're seeing this as a graying population. The lower the income and the education, the more likely one is to become an unpaid care provider in our society. So there's a direct correlation between the increased numbers and a wider gap in incomes in the United States and the fact that the less educated and less financially resourced group are providing more and more care. This means that support for programs about poverty is support for life, and that the divide that may have been characteristic between pro-life and social justice ministry simply isn't there. It is one seamless impact that we will have on our culture, because it really does make a difference on all those levels. Well, we have to make sure that we have the questions broken down that we face in a very concrete way. And I'd like to say that they're so complicated that no one will ever understand them, because that continues to give me a job. However, I want to tell you a secret. It comes down to a couple questions. Don't tell anybody. Okay. We'll try to make this as complicated as possible so that you'll walk away in awe. But I'd rather that you walked away feeling more competent. So the first set of questions that we want to ask is, what do we do with the decision to forego life-sustaining treatment, or treatment of any other kind? Sometimes that shows up in a do not resuscitate order about, heart CPR. Sometimes it shows up in an advance directive, which is a generic term for things we'll hear more about from our other speakers, that announce what our choices are. And sometimes it shows up in a living will. The complexities of these legal instruments I'll leave to subsequent speakers. How do we decide ethically? Because euthanasia, which is simply a kind of suicide or killing somebody else to end their suffering, that's clearly wrong, but we have to distinguish that from the decision to forego what's sometimes called aggressive medical treatment. That is to say, no, I don't want that done. Or if it's being done, I don't want it done anymore. Or I don't want that done for my mother, or for my father, or for my child. For example, medical procedures that are disproportionate to any expected results. I knew a physician who said, he was working in Colombia, and he said, listen, he said, I can work with you and your family. I can take all your money. I can visit your father occasionally and recommend increasingly expensive things. and if I'm lucky, I will extend his life about a month. Or I can tell you the truth, that there's not much I can do, and we can pray. What's it to be? He said, I didn't want to go to the home of the poor and take all their money for nothing. So it was a question of, could he do something that would extend the life of that individual patient? Yeah, he could. But it was so disproportionately burdensome, expensive. He was going to bankrupt the family for no good reason at all. So that would be an example of foregoing treatment, because it imposes an excessive burden on the patient's family. But it could also impose an excessive burden on the patient. I had a good friend of mine who died, and he had progressive amputations. So he had diabetes and all kinds of other complications. So he lost a toe, and he said to me, he said, you know, it was a tough decision to have him take that toe, but the doctor said, have to take the toe, so he took the toe. Later on, he took all the toes. And it was a tough decision, he said, but then he took the foot. Then he took the other foot. Now this was a priest, and about this time it was Holy Thursday, and we had the washing of feet. He sent his prostheses, his artificial feet. People were visiting him in the hospital, and he said, take those, would you have them washed, bring them back? And they did. So at the washing of the feet, they washed these two prosthetic feet, took them back to him. Makes you cry. I loved him dearly. Called me up and he said, they're going to take a leg. He said, when do I tell him no? That's the question. What's the burden? When would we tell him it was okay to say no? When would we say, that's enough? It would differ from person to person in this room. When does the cancer patient say, no, I don't want the double mastectomy? No, I don't want the colostomy. No, I don't want to continue the chemodialysis. No, I don't want the heart transplant. No, I don't want the chemotherapy. When that decision is made, it's not saying, I want to die, I don't like the life I've been given. My sister was given one of these t-shirts by a friend. It said, this is not the life I ordered. She would not wear it. She says, I live the life God gave me, not the one I ordered. My mother was a tough Irish woman, and she handed it on to my sister, who became a tough Irish woman. When we say no, it's a judgment that we make that the burden, either on the family or on the patient, has reached a disproportion, not that it's ineffective. And that decision isn't procedure specific, it's patient specific. Let me say that again. It's not procedure specific, it's patient specific. So when somebody says to me, Father, does the church teach that I have to have this procedure? I said, the church teaches about you having the procedure, not about you having the procedure. It's patient specific. A person has a moral obligation to use ordinary or proportionate means of preserving his or her life. Proportionate means are those that, in the judgment of the patient, offer a reasonable hope of benefit and do not entail an excessive burden or impose excessive expense on the family or the community. This is number 56 of the ERDs. Notice the patient emphasis. So it could be that your father made one decision and it would be different than your mother's decision. It could be that there are two patients in the same condition. One sees their obligation fulfilled by continuing, and the other sees their obligations have come to an end. One who has that leg amputated and one who does not. He took both legs from the knee down. Told me, "How do I look, Dan?" I said, "You look pretty much the same as always." He says, "Well, I'm 2 feet shorter." I said, "Stop it." Now, when I said there's just these questions, there are 2 questions. Here's the first question. Is it futile or is it useful? Because futile treatment does not oblige. Futile treatment does not oblige. So how do we determine is it useful? Well, if it's effective and promises benefit. But it doesn't necessarily provide a cure. I mean, insulin doesn't cure diabetes, but sure is useful. The blood pressure medication I take, I hope is useful. Keeps on ticking. So these kind of considerations of utility doesn't mean cure. And futile is treatment which has no benefit. Well, there are very few treatments that have no benefit, but they can be such minimal benefit as to have nothing to offer. Or they could be a kind of treatment which doesn't really treat the cancer anymore, doesn't really provide even the nutrition anymore, doesn't address the infection which is not responding to the antibiotic. Well, obviously, these things are futile. Second question, is it proportionate? Now, to understand the second question, we have to ask, since heroic treatment does not oblige, is it proportionate? To understand proportionality, you have to understand little kids, the terrible twos. You all had them. You've been around them. But there's a different kind of terrible two. On the left-hand side, we see the terrible twos of burdensomeness. Is it too painful? Now, pain is a funny thing. I don't have much of a pain threshold. I like Novocaine to brush my teeth in the morning. All right, make fun. No, I mean, how much pain is too much pain? I watched people in pain I could never have handled. So, too painful is a patient-specific judgment, isn't it? Too costly. Now, my father was a product of the Depression. 6 figures for Dad meant anything over $5.99. That's a 6-figure lunch. I said, "Dad, it's all right." You know. What's too costly? "Dad, you have insurance." "I don't care who's paying for it. That's too much." Patient-specific. Too damaging, too repugnant, too restrictive of my liberty and activities, too suppressive of my mental life. I had a fellow who was treated for a cancer of the face, and they put a spike into the tumor, and then they heated it. The guy looked like Frankenstein to his kids who were scared of him. It became too much for him. Was it too much for another patient? No, not necessarily. But for him, that particular kind of treatment, he said, "No, I don't want my kids to be frightened of me." Okay, well, that can happen. That he presumed that it was just too disfiguring, too inexplicable to his particular kids, and so he decided. He decided on his perspective. And the benefit, well, will it sustain life? Will it allow time to meet obligations? I have another friend whose dad was a gold miner and who had hidden a gold nugget because he had found this pretty good-sized gold nugget, and it was his nest egg, and he figured when he died that would be how the family would survive. But he never told them where it was. Mistake. But if they told him, "This will keep you alive long enough to tell where the nugget is buried," then it might be the benefit that's, how about the benefit to live long enough to make a good confession? Live long enough to make out your will and testament? Live long enough for your son on the West Coast to make it across country to say goodbye to him? Live long enough to make peace with God, yourself, with others? and to tell him where the gold nugget is buried. I want to live long enough until you hear the magic words being said when Father or some equivalent priest says, "And I absolve you from your sins." Then I'm ready. I'll put up with a lot till that. So proportionality is what is the burden of this treatment for this patient and what is the benefit of the treatment for this patient. Now, in the Declaration on Euthanasia, we have a very important statement which was then repeated in Evangelium Vitae, and it reads as follows: when death is clearly imminent and inevitable despite the means used, one can in conscience refuse forms of treatments that would secure only a precarious and burdensome prolongation of life, so long as the normal care due to the sick patient in similar cases is not interrupted. Let me say it again. You can refuse those forms of treatment which secure only a precarious and burdensome prolongation of life. That's okay. Church says so. And further, there is a moral obligation to care for yourself and to allow oneself to be cared for, but this duty has to take into consideration concrete circumstances. Do you think Mother Teresa starved people to death in India because she didn't put in feeding tubes? Of course not. Does the church teach that feeding tubes must be put in no matter what? Of course it doesn't. Are there times when feeding tubes can be discontinued? Yes. Not procedure-specific, patient-specific. So if you write a document and you say, "I don't want that procedure," wrong approach. You're getting procedure-specific rather than patient-specific. And if you begin to condemn people for doing things because of a procedure, wrong approach. We've got to look at the patient, the concrete circumstances, the benefit and burden to this particular patient is how things go. Tube feed or not tube feed? That is the question. Sorry, Shakespeare. There's lots of ways of doing tube feeding. I call it MANNA, medically assisted nutrition and hydration. Besides, I like the word manna. Has a biblical ring, don't you think? Now, if a patient is dying but not soon, let's say the patient is persisting. Oh, well, there's a diagnosis. A persisting patient. Seems like the answer is built in. A persisting patient, a patient is dying but not imminently dying, needs to be sustained and fed. So the presumption is yes. Now, is it possible that it becomes impossible to feed that patient? Yes. Burdensome to feed that patient? Yes. About that particular patient, circumstances about the benefit to that particular patient, the terrible twos of that particular patient could be looked at, sure. But the general presumption, feed them. Dying imminently. Well, many people at the end of their life can't absorb the various foods and fluids that are being poured into them. Do we have to still keep pouring it into them? No. So when the person is dying very soon, you don't necessarily have the same equation because of number 65, which said that when death was imminent and inevitable despite the means used, one may in conscience refuse those forms of treatment which secure only a precarious and burdensome prolongation of life. Precarious and burdensome prolongation of life. See why that quote's so nice? It helps us. And then lastly, the persistent vegetative state patient. In principle, it's very often the case that in general, per regola generale, it said in the document from Rome, in Italian, sounds like we're ordering off the menu. Per regola generale, as a general rule, we should provide to such patients artificially supplied nutrition and hydration, the manna. So the burden of proof that somebody says this is too burdensome, too futile, rests on them. They have to explain why it would be too burdensome and futile or one of the terrible twos for them. Could they? Yes. I won't make the judgment based on the procedure. I want to make the judgment based on the patient and the situation, the concrete circumstances, because that's what the church tells us we should do. It even clarified this with several comments on this specific item from the Congregation of the Doctrine of the Faith, which I would love to read to you, but we don't have time. And the last slide that I have has to do with pain medication. Do you know right now there's a lot of moves afoot about pain medication and even terminal sedation, it's called. That is, giving people enough pain medication that it puts them into a coma, and then, If you give patients high doses of certain forms of pain medication, it affects them not only by reducing the pain, but it can affect them physically in a way that I'll let other speakers talk about. Nothing should be done with the intention of deliberately hastening that patient's death. No drug, no painkiller should be given with the purpose of hastening death. We can accept that death might be hastened when our purpose is to relieve pain, but we can't give pain medication to deliberately hasten death. Even when the result is decreased consciousness and a shortening of life, if no other means exist, and if in the given circumstances this does not prevent carrying out the other religious and moral duties and telling where the gold nugget is buried, it's licit to relieve pain. It is never licit to deliberately hasten death. So in review, there were two big questions. Is it futile or useful? And the second set of questions is, if it's useful, it still would be okay to discontinue or forego that treatment if it is disproportionately burdensome. Now, how this applies to the decisions we make and the kinds of legal documents available to help us with those decisions remains to be seen. Stay tuned.